That sounds good. Okay, while we're giving people a minute, I do want to put you all to work. I know it's lunchtime, but I'm putting a bunch of things that people are afraid of, possibly some of you that are attending today are afraid of. So go ahead and use your chat or just unmute yourself and tell me what you see here or other things that people fear. And this will give people a couple minutes to log in as well. So again, use the chat, go ahead and unmute. Very informal here. No one's afraid of anything? There we go. Perfect. Terracotta snakes. Me too, friends. Kelly Hill's severe storms, spiders. Yep, I'm afraid of all of those as well. A big germaphobe. Fire. Yep. Lightning. Those are good ones. I'm kind of public speaking right now, which is the top left, so that's my fear. What else? Anything that's on this or not on this list that people fear? Oh yeah, we live in Michigan. Driving on ice is an excellent one. Yep, fear of loss or death. Grief is actually one of the most universal kinds of adversities, but there's actually not a ton of research about grief as a form of adversity, which is kind of interesting. Yes, heights, absolutely. That's represented in the top right. How about this middle one? Does anyone know what that one represents of the child? Rejection. Yep, fear of rejection or exclusion. Exactly. Yep, and then fear of the dark is on the left. So awesome. I so appreciate it. So my name is Hilary Marusak. I am a neuroscientist by training at Wayne State University in Detroit. I think I talked to a couple of you earlier this year about cannabis. We'll be talking about something totally different today. We'll be talking about the neuroscience of fear and anxiety related disorders. So my disclosure is I am not a clinician, so take all of this with a grain of salt. You guys are the experts in that area and how to translate this into patient care, but I am, I can answer any questions about kind of the neuroscience of these disorders. So why did I start by asking you what people are afraid of? Well, fear is actually a universal emotion, and fear, I didn't mention that one here, is kind of a panic disorder, like being afraid of having a panic disorder or a fear attack is what I'll refer to it throughout. And fear is common. It's a universal emotion that's experienced by some of the lowest animals as well. If you have dogs, which I have one sitting next to me by my feet, animals also experience fear, probably for different reasons, but it's a very universal construct. And in the psychiatry space, which is where most of my research is focused, I'll refer to DSM-5 disorders as fear-based disorders throughout. And what I'm talking about really is a collection of anxiety disorders on the left, as well as post-traumatic stress disorder, which is actually has been moved out of the anxiety-related category into its own category in the DSM-5, but nonetheless shares this similar feature of having fear as really the core underlying feature. So all of these disorders have fear about something. So take, for example, specific phobia. A couple of you guys were saying you're afraid of spiders and snakes. I am as well, but fear of specific stimulus or stimuli is specific phobia. Social anxiety is fear of scrutiny or rejection or unfamiliar people or social circumstances. Panic disorder, as I mentioned, is really fear or anxiety about having those recurrent panic attacks and so on and so forth. And of course, with PTSD, it's very specific to fear related to that trauma memory of that traumatic event. So throughout this talk, I'll refer to them as fear-based disorders. Again, from a neurobiological perspective, they all share that really common feature of fear, dysregulation, and fear response. So what's fear good for? Well, it keeps us safe. It's very evolutionarily adaptive to be afraid of things that can cause harm. And, I was on a hike in Colorado a couple years ago and I saw a snake on a path and I don't like snakes. They can be very dangerous. So that's very adaptive to have fear about that stimulus, which could cause danger. But, in today's society and in different environments, fear can be maladaptive when you're showing that same kind of fear response, say when you're a child and you're trying to pay attention in a classroom, for example. So fear can be adaptive, but in certain circumstances or contexts, it can actually interfere with learning and other key kind of occupational, social, and academic performances. So, like everything, I think that, fear can be helpful. And I do want to differentiate between fear on the left and anxiety on the right. These are very overlapping constructs, and neurobiologically speaking, they share a lot of the same brain regions, which I'll come back to in a moment. But the real difference between fear and anxiety is one, the proximity of the threat. Like if you are about to be eaten by a shark in this case, that is an acute fear response versus anxiety is more diffuse. It's thinking about things that could potentially happen that aren't acute threats. And there's also a difference, in proximity to threat. So if you see a tiger, that's 2 miles away, that's not as fear-inducing as something that's really close. So there's that distance factor. There's the timing factor. Are you afraid of an exam happening tomorrow, or is it happening in a couple weeks, which gets more into the anxiety? And then, it differs based on this more diffuse anxiety of fear or anxiety of what's happening. So as I mentioned, there's a range of fear responses. You've probably seen this inverted U for the stress response, where there's an optimal level of stress. And same with fear and anxiety. You have to be a little bit anxious to study for that exam, or else you're not going to do very well. But once you pass that point of kind of diminishing returns, too much anxiety or fear can be maladaptive. And that's really what we talk about with anxiety disorders and fear-related disorders, that it's either too much that it's impairing, or it's an inappropriate response. For example, if you're showing a fear response to an animal at a zoo where the context is not correct, then that might impair your life. So why does this all matter? I think, most of you on the call are clinicians, so you could probably tell me better than I can tell you, but fear-based disorders are some of the most prevalent disorders, psychiatric disorders in the general population. And about 1 in 3 children and adolescents will experience an anxiety disorder before age 18. So even in our child and adolescent populations, it's really important. And I study anxiety in kids. We think anxiety is super interesting because it often precedes and predicts depression, suicidal thoughts and behaviors, other types of psychiatric disorders, and substance use disorders. So it's really important to pay attention to anxiety in particular. And what I've already alluded to is that anxiety can begin very early in life. And again, it's adaptive in some cases, but in some cases can become maladaptive. So this is the age of onset distribution of the various fear-based disorders I mentioned. So throughout this talk, I'll also be talking about PTSD. So I just want to clarify what I mean by PTSD and what I mean by trauma, which is that criterion A for developing PTSD. And trauma is one of those things that's used colloquially, so it kind of loses its meaning. But according to DSM-5, trauma has a very specific definition, and that's exposure to actual or threatened death, serious injury, or sexual violence. And usually that's direct experience. It could be witnessing, it could be learning about that happening. For those who are clinicians, there is sort of this vicarious trauma that can happen after repeated exposure to details of the traumatic event. But there's a lot of different types of experiences that qualify for DSM-5 trauma, including not only our first responders, our military veterans, and combat exposed military individuals, but also car accidents, sexual assaults, witnessing violence, hearing gunshots can even be traumatic if you see some of the aftermath. So a lot of things qualify, and children also experience those things, right? So trauma is also really common. Again, I'm preaching to the choir here. We know that 70% of individuals will experience a trauma, one or more traumas in their lifetime, and multiple traumas is the norm and not the exception. And again, many of these are experienced within those really vulnerable periods of brain development in the first 2 to 3 decades of life. And although many people will experience a trauma, only a subset, you all know, develop PTSD. It does vary according to the population. In some, urban areas or military populations, that rate is much higher. In our Detroit youth sample, so these are adolescents, we're seeing PTSD rates of 20%, so extremely high in Detroit. So again, this really highlights the importance of paying attention to this clinically. So what I will attempt to do today, just to give you a lay of the land, is provide you some basic understanding of what brain circuits are important for anxiety and PTSD. And of course, I could probably give a 10-hour lecture on that aspect, and then really dive into how trauma in particular impacts brain development. Again, we could go into more detail, but I'll try to hit the highlights. And that's important because we know that trauma is pervasive, as we mentioned. It's also one of the chief risk factors for anxiety and other fear-based disorders. So that's why I'll go into that specifically. I'll mention briefly some age-specific signs, and again, you all can tell me better than I here. But I do want to highlight at the end and then kind of a high note. So what's coming down the pipe in terms of exciting neuroscience-informed interventions, and then some recovery strategies that I'll share with you all. So what's happening in the brain when you're experiencing anxiety and PTSD? So I'm not going to read this out loud, but this is just a quote of someone who's experiencing a panic attack, which I'm sure probably everyone in the audience has either seen or experienced themselves. And what they're describing there is really an acute fear attack. And at the level of the brain, this is really interesting, again, because a panic attack, we can have that isolated fear response that has a whole body response. Those signatures are really apparent across the different fear-based disorders, as I already mentioned. And if you look at the neurobiology, you see that fear or panic attacks have this really diverse collection of either physiological or subjective effects on the body, right? There might be a racing heart, sweaty palms. I'm sure we've all felt this. In animal models, you see freezing behavior, you see that fight or flight response, and then we see some biological stress markers elevate. And it turns out, because of animal research, we've been able to really highlight that there's key areas that are linked to all of those different physiological responses. And they actually have very different areas in the brain, all very low areas that are, again, available in animal models as well, which really makes it nice for us. I work with humans, but we're able to really translate work done in animal models directly to humans, which has a ton of benefits. So what's orchestrating the fear response? How many of you guys have heard of the amygdala, right? Like that is what we think of as our canonical fear center. The amygdala is actually a collection of subnuclei. It's not this big, just, homogeneous structure. It's a collection of different subregions and then subnuclei within those subregions, but that is what triggers the collection of brain regions that lead to that different fear response. Sorry, my dog is not happy right now. He's having an excitement response. But those are all really well-characterized circuits in the brain that once the amygdala is sort of triggered by a fear stimulus, we see a collection of different brain areas that orchestrate the different types of conditioned fear responses that we see. Okay, so again, I gave you the example earlier about if you're, hiking in the woods, you see something that looks like a snake. How many people have seen like a stick and thought it was a snake? Because your amygdala is really sensing the environment for danger. So if you see a stick or something that looks like a snake, or you see a snake, your amygdala very quickly and rapidly says that this is a biologically relevant stimulus for you to pay attention to because that's evolutionarily adaptive, that could actually kill you. And it quickly triggers that fear response. So you could either run away, your heart rate increases, your blood pressure increases, and things like that. So it's very adaptive. And interestingly, if you're more interested in what the amygdala does, there have been some really interesting cases of people who have actually tumors in the amygdala. And in animal models, you can actually lesion that area and see what happens to the animals. Primates are also afraid of snakes innately. That's an innate danger. And those animals that have Kluver-Bucy syndrome, or basically their amygdala are ablated, they are not afraid of snakes at all. And so they'll just walk right up to them. So that just goes to show the importance of the amygdala and really driving that fear response and keeping us safe, right? So what happens in things like PTSD? Well, one of the things that the amygdala does really well is it takes all of the information from your environment, especially when you're exposed to a trauma. For example, someone in the military might be driving down the road in a Humvee, and all of a sudden that might explode. So that's your criteria in a trauma. That's your when your fear memory is being established. So again, all of that information that is occurring in the environment at the time of that trauma or that traumatic event is being consolidated in the amygdala, and that's driving that fear response. So that could be sights, it could be sounds, it could be smells, it could be time of day, it could be something random that they're not even aware of. But again, that is really helping to keep people safe, because if you're exposed to anything that reminds you of that trauma, then you might be in danger. So what happens then if you're back at home and you're driving down I-75, and again, you're in a car, which is a stimulus, and then you hear a loud noise. So that's when people with PTSD, for example, could have that trigger of that fear or that panic attack, because the amygdala is sensing that there's similarities here. So it's triggering that same fear response, which again is an adaptive process to keep us safe, but in PTSD, it becomes maladaptive. So what we talk about with PTSD neurobiologically is that there's either something that happens where the fear memory itself becomes super well consolidated, or it can't be regulated very well once it's already established. So that doesn't mean you're just doomed to just have this fear response the rest of your life. There's actually a lot of ways to regulate fear. So one of the ways that you might all use clinically is something called fear extinction, which forms the basis of exposure therapy, which is a core component of some forms of CBT. So on the right is kind of this cartoonized image. If you just relax and trust me, Miss Snyder, in 45 minutes, your fear of thunderstorms will be completely gone. So, poor Miss Snyder is just being exposed to lightning bolts over and over again in a safe environment of a therapist's office. And, it sounds really silly, but think of, spider phobia, where you might start with, an image of a spider, and then after repeated sessions, where the fear memory is being better suppressed, they might be able to hold a spider at the end of the CBT course, right? So that's the idea, is that repeated exposure creates a new memory. It never gets rid of that original fear memory, but it says, hey, you're safe. You don't need to show that fear response. Of course, there's a lot of limitations to therapy. About 50% of people don't respond. You all know better than I that it's really time intensive. It can be very difficult, especially with people with PTSD, where part of it is really reliving and recounting their traumatic events. So very distressing. And then the fear memory, again, it doesn't ever go away. If you're back in something that reminds you, or back in an alley in which you've been assaulted in, you could have that fear memory come back over time, and it diminishes over time too. So a ton of limitations with this type of treatment. So what happens with memory consolidation? So I've been talking a lot about that, and that's what happens when the fear memory is being stored for long term. And then also when you're doing therapy, again, you're creating a new memory. So there's this interesting thing with memory where every time it becomes active again, you have to go through the process of reconsolidating it in the brain. So I kind of think about it as like if you have a file cabinet, every time you look at a file, instead of just putting it back into storage, you're actually changing something about it every single time. So it's never exactly the same as the original. And that explains a lot why, first person, reports in court are not super reliable. People will often have terrible memory, myself included. And it's because that over time, uh, your memory is being reconsolidated and changed every time that you modify it. So this is actually for scientists developing new treatments, this is actually really interesting because it provides some opportunity to interfere with that initial memory when it's being consolidated. So think of people that come to the emergency department right after a trauma, like a car accident. Is there some sort of intervention we can give them to prevent the consolidation of that fear memory? That's something that's actively being studied. And then later down the road, because we don't often see people right immediately in the aftermath of trauma, but more when they've had that fear memory established, can we reactivate that fear memory maybe in therapy? And there's something that we could do to modify that to suppress it more over time? And again, there's a lot of ways that are being studied in the lab to do that, including medications, but also behavioral approaches that I'll come back to later on. So another key brain area is the hippocampus. You probably have all heard of the hippocampus as being one of the key areas for PTSD. It's one of the most common findings we see in PTSD studies is lower volume of that structure. Hippocampus is involved with learning, emotional memory formation, and it plays a really critical role in regulating our stress hormone responses, like cortisol, which is the endpoint of that HPA axis. It also has this double-edged sword because not only does it regulate our stress response, but it actually is sensitive to the effects of those circulating stress hormones. So, which is what a lot of people think is why it's very sensitive to stress. In some of the early studies by Bruce McEwen in animal models, when they stressed out those animals, they actually saw an expansion of the amygdala. Again, that's our canonical fear center in the brain. And they see a retraction of neurons in the hippocampus. Their dendrites become um, more suppressed and in the prefrontal cortex. So again, that's important for that memory consolidation. And also the hippocampus tells you what's safe. It's taking in contextual cues and saying, hey, I'm in a therapist's office, I'm safe, I don't need to be showing that fear response. So that could contribute again to the that fear memory kind of rearing its ugly head over time. So just to wrap up this section, these are some of the key brain areas. So prefrontal cortex and other areas of the frontal lobe. So that includes regions of the cingulate gyrus. They are important for regulating fear, so top-down control. They're underdeveloped in youth. Again, that's a reason for risk-taking and other behaviors. You know, the teenage years has a lot of emotion dysregulation. So it's largely attributed to that lack of the underdevelopment of those frontal areas we often talk about. And then the amygdala, we've been talking a lot about. It's really that canonical threat center, things that are salient or biologically relevant, which also means rewarding cues, is hyperactive in those disorders. And then the hippocampus, which again takes in contextual information, is often impaired in PTSD and in kids exposed to trauma, which is what I'll come back to later on. But I do want to say, as a neuroscientist, these are some of the key areas you'll often hear about. And I think for talking to patients, these are some of the areas you want to hit on. But of course, we're leaving out the entire rest of the brain, which also plays a role in a lot of these processes. So I don't want you to think that I'm just oversimplifying. There are a lot of complex networks involved in different parts of the fear response, but I think these are some of the highlights. Any questions? Feel free to put them in the chat as well. Okay, I will keep going, but do not hesitate. Okay, so let's talk about trauma. So I keep mentioning trauma as one of the chief risk factors for not only PTSD, which is what we think about, but almost virtually all psychiatric disorders. And I spent most of my career studying how early trauma in particular affects brain development because we know it's super sensitive to those effects. So I've probably shown you guys this before. We all know that regions of the prefrontal cortex, you know, the front of the brain are some of the last to develop. And there's this interesting difference in the development of the prefrontal cortex versus limbic regions like the amygdala, where those come online much sooner. So you often get very, you know, hyperactive or reactive fear responses or impulsive behaviors during adolescence, which characterizes a lot of what we see in adolescent behaviors versus that prefrontal development that really controls emotion and is involved in things like future-oriented thought and planning is really underdeveloped. So this is by design for a lot of reasons. We want our adolescents to be kind of flying the proverbial nest, but of course that could also make them sensitive to fear-based disorders during that time. And again, I'm not going to spend too much time. I'll just give you a couple highlights. We know that trauma itself does change the developing brain. We don't know if all of those changes are bad, right? Because many people will experience trauma and be resilient. Only a subset will develop PTSD. So a lot of these changes we don't know are whether they're bad or not. We think that trauma sensitizes the brain in ways that could make people more susceptible to disorder. But again, this is not an end-all be-all. We know that there's a lot of ways to buffer this as well. So we've shown that kids that experience trauma have differences in how their amygdala responds during fear extinction. They have a lower ability to regulate their emotions. And then they have lower attentional control, which could explain really the tight relationship between trauma and externalizing behaviors in youth. And we know that a lot of these changes last into adulthood. This is a large study showing that there are differences in how the amygdala responds across a variety of different tests using neuroimaging. So there's higher amygdala response in people that experienced trauma as a child, so decades prior. And also their prefrontal cortex is less engaged. So it really fits with that same pattern that maybe that limbic prefrontal misbalance is exaggerated and that lasts for several years after the trauma happens. But of course, with anything, there's a ton of open questions. I already mentioned, we see changes in the brain. We don't know which ones are adaptive yet. We can follow kids as they age to sort of piece that out, but of course that requires very large longitudinal studies. So that's something that the field is still grappling with. And then, of course, I've been saying trauma is like a catch-all, but we know that there's a lot of different types of traumas, right? We know that there's differences in interpersonal versus other types of trauma, like a natural disaster, the perpetrator of the trauma, if it's a close loved one, if it directly happened to you versus if you just witnessed it or heard about it, physical abuse, sexual abuse, all of those things look like they matter. And of course, in humans, it's really hard to parse out, right? Because a lot of those things co-occur. And, a lot of people have developed different ways to look at trauma and adversity more broadly. This is the threat deprivation model, which I think is really nice. So threat exposures could be something like physical or sexual abuse versus deprivation is more, I think, like poverty, think institutionalization, neglect, where you're lacking resources. So threat is something where you're adding something that's different that causes harm or could cause harm to individuals. Deprivation is really lack of resources. And of course, even exposures have a lot of overlap. Some, like poverty, could include threat, but it also could include deprivation. And it looks like these two different dimensions of adversity have different effects on the brain, with threat-related exposures more relevant for the regions I just talked about, and deprivation is more relevant for like learning and emotional memory and cognitive functioning areas. Obviously, really hard to measure all of this in humans, right? And then, there's a lot of factors that influence outcomes. Age of onset, chronicity. Is it a one-time car accident or was it repetitive use over, decades? Sex and puberty play a role here. So a ton of unanswered questions. So what can we do about all this? There's actually a lot of positive environmental buffers or risk factors if you look at it at the flip side. Here's a collection of different environmental factors, starting with the family and kind of the caregiving relationship that I've known to buffer the stress response and risk for anxiety. And we also know that there's individual differences. Sleep is a big one, and that's also a double-edged sword because we know that things like anxiety and depression can interfere with sleep, and that further exacerbates some of these symptoms. But stress and environment also play a role here. And the last one I want to underscore too is really important. Some of our research at Wayne State is showing that the air that kids breathe can increase their risk for not only asthma, but anxiety. So that really, I think, for all of us puts the onus not so much on the individual who's, coming in for med management or therapy, but also as a society, like how are we regulating our exposures in the air that we breathe and the water that we drink and things like that. All right, any questions? All right. I'm just wowing you guys so much. There's no questions. I'm just kidding. Okay, so again, I am not a clinician, but I do want to highlight that, of course, the age of the child really matters. And I know there's a preschool version of PTSD now specific to the DSM-5, which is something new. And that was really because we know that kids express these symptoms differently than adults. And kids can't easily verbalize a lot of these symptoms in the same way that adults can. So obviously for you all, it makes it really challenging. So age really matters. There's a lot of different ways that children may express their fear and anxiety, and a lot of them are behavioral, they're physiological, so things to look out for. And of course, in adolescence, that's a period of heightened risk-taking in general, but again, compared to other kids that age, are they showing, excessive, is it excessive and unique to their peers? So again, I want to end more on a positive note. So what can we do about all this now that we've understood how fear memories are formed, how they're consolidated, that they never truly go away, but that there are ways to manage them or to reduce their expression. So why is this important though? But because we know we have treatments, many of them work. They don't work completely well and for everyone. So I think there's a lot of room for improvement. But I do want to highlight some of the first line treatments we do have. We do have psychotherapy. There's a ton of variations of this. Again, you guys can all tell me better. For pharmacotherapy, we do have antidepressants that work well to combat some of the symptoms of fear-based disorders. And then there's a ton of other things that you are all using, I'm sure. Mindfulness-based therapies are really common. We're seeing, in this more virtual world, a lot of internet-based interventions. I'm not even going to talk about the issues with ChatGPT therapy right now. Maybe you'll have an expert on that soon, but a lot of different treatment approaches that include pharmacotherapy and psychotherapy. But as I've been alluding to, a lot of these treatments are really difficult and exhausting, and they can be prone to relapse. So, on the pharmacotherapy side, some of the symptoms can be addressed. A lot of patients on SSRIs, for example, are left with, at least in PTSD, more the hyperarousal, hypervigilance symptoms. Maybe some of the negative cognitions subside, but it gets at some, but not all of the symptoms. There's side effects to medications, right? A lot of them are slow acting. They take 4 to 6 weeks in some cases. And then benzos could be useful in the short term, but they're poor long-term use. A lot of side effects there as well. The other problem is that these disorders are super heterogeneous. There was a study that came out in 2013 saying that there are 636,000 different ways to have PTSD if you just look at the whole DSM-5 criteria or DSM-4. So, when we say PTSD, that might look a lot, that might look different clinically, but also when we go to look at the brain patterns might be really different too. So it's really hard to put people into bins of PTSD when they show very different, biological signatures. And similar for anxiety, we see very different patterns across different individuals. And then we know that a majority or almost half of people in some cases don't respond to treatment, or they only show a partial response. So that leaves a lot of improvement to really do better. So I want to talk about some of the approaches that are being explored currently and that I think are a little bit promising. I'm not capturing all of them, but I think some of them are important to mention. So one is what I mentioned, where we're kind of taking advantage of the process of memory consolidation and reconsolidation. So again, every time you recall a memory, it has to be reconsolidated and it can be changed. So when you first lay down that trauma memory, this is like the golden hours that I mentioned. If you have someone who comes into the emergency department for a sexual assault, for example, is there something you could do immediately, during hospitalization or after to prevent that or disrupt that fear memory as it's being consolidated? So that's something that's being actively explored. And then again, down the road, once that fear memory is already consolidated, which is probably when you're seeing most of your patients, is there something that we can do to augment the effects of prolonged exposure, for example? And that could either be through pharmacotherapy or behavioral interventions. And I'll talk about a couple ways we're exploring that in my lab in a couple slides. Another promising approach is neurofeedback. I'm sure some of you use this clinically with heart rate or other measures. This is being explored with neuroimaging as well. So there have been some studies where they put people in an MRI scanner with PTSD and they have them view trauma-related words. So again, looking at that, getting that fear memory to be kind of triggered, so to speak. And then they're targeting activity in the amygdala or a region of the posterior cingulate cortex. And they're basically seeing if people can control their own emotional reactivity or dampen it down when they're actually seeing how their brain, those brain areas are responding. So very similar to something like HRV, when you have people look at their HRV and see if they can regulate that biomarker. And it actually looks like, at least in this meta-analysis of PTSD studies, that they are seeing significant reductions using this method. EMDR is another really promising approach. I don't completely understand how it works. I don't think anyone does, but you might have seen this clinically with a light bar. And for some reason, the rapid eye movements kind of help process and resolve distressing memories. And there is some signal, it's a small effect size, but there is some signal for reductions in anxiety, PTSD, and depressive symptoms. So very promising there. In my department and others, we're exploring different forms of neurostimulation. So these are non-invasive measures where you're either stimulating the brain with a magnetic field or with a direct current pulse. So TMS is transcranial magnetic stimulation. You probably see those little figure-of-8 coils where you run electricity through the coil, and that induces a magnetic field into the brain, which causes changes in electrical activity. So there's no shocking or anything like that. People kind of just fall asleep when it's happening, but it is FDA approved for treatment-resistant depression. It's also being explored for PTSD, for GAD, for substance use disorders in our lab. So very promising there. And then TDCS is kind of similar, but you're actually running a direct current between two different electrodes. And I would say it's not as effective because the skull is actually not a great electrical conductor. So a lot of the activity doesn't get into the brain tissue, which is where we really want it. So I think TMS can be a lot more targeted and more effective for that reason. Another area that we and others are exploring are cannabinoids. So cannabinoids are compounds that are derived from the cannabis plant. They can also be synthesized in a lab. The most common and well-known are THC and CBD, or cannabidiol. So we're actively exploring whether different compounds can be used to treat things like PTSD and anxiety disorders in the lab. Obviously, cannabis is very widely used for self-medication, and if you tuned into my, earlier talk, a lot of people use it for those things. There's not a ton of evidence that it does help with things like anxiety and PTSD. But also with the cannabis plant, it's really difficult to dose because cannabis is such a broad word. Like, are you talking about like a 5 mg edible? Are you talking about a 30% THC flower that you're smoking or vaping? Are you talking about a high potency 90% THC concentrate? There's like beverages now, it's getting insane. So it's, therapeutically, it's really hard to study and to dose for that reason. But I will say some of the exciting things happening are really targeting the endocannabinoid system, which is what cannabis works on. And there's a lot of different ways to do that. There's a lot of different receptors and enzymes that work in the system. So a lot of people are very interested in targeting different components of the system. Fa is an enzyme that breaks down our natural cannabinoids in the body. So there was a lot of excitement about using a Fa inhibitor as a medication to increase endocannabinoid signaling. Unfortunately, there's really two very high-profile trials with PTSD that failed recently. So there's been a lot of discussion about, why that is. But even despite the failures with those two studies, I think that the system itself is very exciting. There's a lot of recent interest in this, and I think that we'll be able to understand different ways to target it in the future. Again, bottom line is there's not a ton of evidence to show that cannabis or cannabinoids can improve psychiatric disease in general, not just anxiety and PTSD. So one shameless plug, I did mention we are doing studies. We are looking at cannabis in veterans with PTSD. So I'll leave this QR code up for one moment. If you do know anyone living in the Detroit metro area who might be interested in learning more, we pay very well. They get free cannabis for doing this study. So definitely refer them to us. And I can share the slides afterwards as well. All right, just paying attention to the time. Okay, so I want to touch on a couple of more areas before we wrap up here. So one is psychedelics. I'm sure all of you guys are getting questions from your patients about this. So it is a super exciting area. Again, with cannabis, there's a lot of different psychedelic medications, so it's really important to talk specifically about what people are using, what they're interested in. The data are really compelling. There's a ton of issues with the state of the literature right now that I don't have time to get into. But I think that, in the next couple of years, we'll see some promising developments, in terms of MDMA-assisted therapy. Psilocybin is showing some really promising effects for depression, end-of-life anxiety, things like that. And then ketamine is FDA approved for treatment-resistant depression. There's a recent oral or nasal spray that was approved called Spravato by J&J. So that's being explored in other areas as well, like anxiety, PTSD. Okay, so I'm going to pivot right now to some non-pharmacotherapy approaches. And I'm going to start with physical activity because that is one of the most powerful antidepressants we have. And it does show that physical activity has efficacy in reducing anxiety and depression, also improving sleep. And some studies in anxiety have been a little bit more equivocal. But in our own lab, again, I work with mostly children, we're finding that after they do a 30-minute treadmill exercise, stretching condition, even a seated meditation, we see a significant reduction in their anxiety symptoms and their depressive symptoms. So that's really powerful. That's something that people can do. 30 minutes is all it took for these kids. They did a light intensity stretching, they did a seated meditation, and we are seeing benefits across all of those conditions. So we work with a lot of schools. We work with Dearborn and Detroit Public School Community District, and teachers are always interested in things that they could do in the classroom. So we're very interested in seeing if we can pare this down and get kind of the biggest bang for your buck. And if you do a 5-minute yoga break in your classroom, you'll be able to get some of these benefits. And for cognitive performance, if they have a test coming up, can they use that to augment their performance? But again, something that patients can do on their own, they can couple it with different therapies, and they can see benefit. Sleep is another one I alluded to earlier. The data are pretty strong that sleep can have beneficial effects on anxiety and PTSD. There's different treatment approaches, either psychotherapy or pharmacotherapy to address sleep-related issues. Mindfulness has become really, really kind of a hot topic over the past couple years. And the data do support that it does have some medium to large effects versus inactive controls. So, there was at least one study I saw where mindfulness it was basically equivalent to an SSRI treatment. So, a lot of what we look at as scientists is what is the comparison group. So compared to doing nothing, mindfulness is better, but could that be because they're, getting out of the house or they're with a social group? But I think it was really promising that at least one study found that an antidepressant was equivalent to a mindfulness-based intervention. So it does show that mindfulness does have some beneficial effects there. And then diet, of course, we know that ultra-processed foods is kind of, unfortunately, a hot topic right now. The ketogenic diet is really popular for epilepsy. It's very effective in that space. there are a lot of people in psychiatry now exploring the ketogenic diet and other forms of dietary interventions for serious mental illness, showing really, really promising effects. In preparation for this talk, I did find a small case series study that reported remission of symptoms in 3 adults who have MDD, GAD, and anxiety disorders within 7 to 12 weeks who were on the ketogenic diet. So, metabolism it's an exciting area of neuroscience because the brain is kind of a hybrid engine. It does run on ketones and glucose, and there's this really tight connection between diet and metabolism and mental health. So I think we'll hear more about that as the research progresses. And then finally, I want to just shout out to stuff we're doing at Wayne State. We're looking at combining different treatments together. So that could either be a behavioral treatment like exercise, where we're having kids in this case do a fear extinction session, basically akin to CBT, and then we're asking them to run on the treadmill. And we're hoping that the next day when they're not running anymore, that the ones who ran on the treadmill show better fear extinction. So they're showing lower conditioned fear response. And this is a laboratory-based study. It sounds really silly, but if it's showing effectiveness in our laboratory-based study with brain imaging and with different physiological markers of fear, the next stage would be to bring this to a clinical trial where we have kids actually do a CBT session who have anxiety, and then we would have them either run on a treadmill or do a control condition. And we would hope that they would require maybe fewer CBT sessions, they would respond better to CBT, show greater reductions in anxiety. So it could be, a relatively interesting and easy add-on for therapy. On the pharmacological side, we are looking at different cannabinoids like THC and CBD, and we're pairing those with psychotherapy again. We're also interested in different dietary interventions and other ways to modify the system. So can we put two highly effective treatments together? Can we use neuroscience to tell us how to better augment that treatment? We do have a clinical trial right now for people with anxiety disorders where we're using cannabidiol and combining it with CBT to see if that has better reductions on anxiety symptoms. Okay, so we do have a couple minutes left. I want to touch on some recovery strategies, but before that, anyone have any questions about any of the interventions I mentioned? Take a quick break. Okay, thank you, Chelsea, for letting people in as well. Okay, so ending on a high note. So how can we leverage what we learned today to help clients? So a lot of different ways. Again, I'm not a clinician, so take this as a grain of salt. But I do have references here. So a lot of what we talked about with kind of exposure is really important, I think, because again, fear extinction is one of the key ways that we can actually regulate or modify a fear response. So exposures, anytime you can incorporate that into your practice, will help with reducing fear. There's a lot of different ways to do that, especially with younger children. Using play, incorporating those metaphors is really important. And then I think we'll see more about this, but ways that we can use the neuroscience to augment what is happening in fear extinction, to really improve emotion regulation skills, so that prefrontal control over those limbic areas. And then mindfulness is really interesting. We've actually shown that mindfulness can help kind of strengthen prefrontal control over those limbic areas. And that's something that kids can do. I've seen 2-year-olds do mindfulness. So, there's always ways to approach it and to adapt for different ages. And then family and social environment matter a lot. And as a neuroscientist, I'm very guilty of this. We bring a child into the lab, we study them in that moment. We don't think a lot about their home environment, their context, their neighborhood. And it turns out that a lot of us are realizing that those things do really matter. That neighborhood, I showed you that air pollution, all of those exposures impact the brain. And it's important also to really think about how we can leverage that for recovery. So again, I will share the slides with you, but here's a couple of resources that I found really helpful. 0 to 3 is more trauma-informed practices for early childhood that really puts this neuroscience, I think, into a really informed practice. The U.S., the Veterans Affairs has a PTSD for providers toolkit that I think has a really great overview of some of the available treatments for pediatric as well as adult spaces, different types of treatments that I mentioned today as well. Uh, the National Center for PTSD has a research quarterly that I think does a really good job of just telling you what's new and coming down the pipe for interventions, for drug research in the PTSD space. There's also some studies in children as well. And then my two friends, Josh Sisler and Ryan Haringa, both study PTSD in youth. And they put together a really nice literature review on the neurobiology of PTSD in youth that I think puts all of this into a really nice context and talks about interventions really to strengthen developing brains and mentions some of the other things that I talked about. So highly recommend you read that if you work with kids with PTSD or adolescents or even young adults where their brains are still developing. Okay. So just to try to summarize everything that I mentioned today, if you leave today remembering a couple things, I really do hope you remember these things. One is that it's not bad to be afraid. It's not bad to be anxious. Those are really key survival skills, and it can be dangerous if you lack those things, like if there's a tumor pressing on your amygdala, for example. But they can become maladaptive based on context or based on showing excessive fear response, as we talked about, and that's really when it becomes a fear-based disorder. I want you to remember the importance of trauma, especially trauma during early life, that it can change the way the brain in ways that persist into adulthood. But again, that doesn't mean that those brain changes are destiny. We know a lot of people experience trauma. They will be resilient. They will show post-traumatic growth. Only a subset will go on to develop things like PTSD. So that's a big question for neuroscience is why is that? And are there ways that we can predict who's going to develop PTSD, which brain changes are maladaptive, and how can we leverage that to bolster recovery and to prevent the development of PTSD? And then finally, recovery is possible. You know, as older adults, it can still change our brain. There's a lot of exciting treatments. I think it's a really exciting time to be in psychiatry. So I don't want you all leaving here and thinking that all is for nothing. You know, there's a lot of ways that people can take control over their recovery with things like diet and sleep that, you know, sound so silly, but those are really foundational and they do actually have signal, especially when paired with other types of treatments. So with that, I will just say thank you. The QR code will link to some more resources about myself, my lab. If you are interested in any of the studies, please email me. I love questions too. And then if I can be a resource about anything related to PTSD, trauma, anxiety, you name it, you know, that's what I'm here for. So thanks, everybody. I appreciate it and happy to answer any questions.
Just want to say thanks again, Hilary, for joining us today for today's Lunch and Learn. We really appreciate your time. And just a quick reminder for everybody that I will post her slides. She's graciously agreed to share them with us and the recording to Basecamp within this next week or so.
Cool. Thanks, everybody. And I'll also put my email in the chat. If there's something that comes up later on, do not hesitate to reach out. All right, great. Thank you. I can stay on for a minute if anyone else has any questions, but everyone else is released. Thank you very much. Give you 4 extra minutes. Man, my room got super hot during this.
I was worried the neighbors like power washing, and I was like, oh, right before you started, I was
Oh,
like, never
no.
fails.
And someone knocked on my door. Did you hear my dog lose it? He was like, I'm like,
Yeah.
no.
Oh, what kind of dog do you have?
We actually have three right now. We have a foster dog too from Texas. We think he came from the floods, but he's like a poodle mix, and then we have an Australian Shepherd and a Jack Russell mix. So a lot of energy in our house.
Oh yeah.
How about you? Do you have animals?
Yeah, we've got two bigger dogs. I have a German short hair pointer and a Weimaraner.
Oh my gosh, those are like love bugs though. They're so
Yeah, they
sweet.
are.
Oh,
Lots of energy though too.
yeah,
So I get the
yeah.
energy.
Oh gosh, yeah. Pointers are really cute though.
Fun.
Awesome. Well, thank you, Chelsea. It looks like no
Yeah,
other
great.
questions, but I'm available if anything comes up, and I will send you the recording right now before I forget.
Awesome. Yeah, great. Thanks again for everything. We
Oh,
appreciate it.
of course, good seeing you. Thanks for the
You
opportunity.
too.
Bye bye.
Yep. Bye-bye.